Bismillahirrahmanirrahim. Assalamu alaikum. Today we will talk about supraventricular tachycardia SVT. What is supraventricular tachycardia and how you will face the question in the exam, because you will definitely face 2-3 questions in MRCPCH-theory exam, like foundation of practice, theory and science, and applied knowledge in practice. So what examiner wants from us, we should know how they are giving the questions. So SVT, supraventricular tachycardia, when I was appeared in the exam of theory exam of MRCPCH, I saw a question. I diagnosed from the history about supraventricular tachycardia, but answer was not that much easy. So I think I did wrong. So the things which we should know about SVT. Today we'll discuss about this. Okay, so today we will discuss about the definition, and in definition I will just tell you about something of basic things of SVT, like anatomy and physiology of the heart, and then we will discuss recognition and assessment. If you are sitting in an OPD and you have received an older child who can speak, it's very easy that the child will tell you that my heart is racing or I have a palpitation. But if it is a baby, small baby infant, so they are unable to speak, how you should recognize. So these are the things which examiner are asking. Investigations, usually there are no investigations other than the ECG, because if it is first presentation, definitely you should refer the baby to the cardiologist. Differential diagnosis. Differential diagnosis, we will discuss about the palpitation, what are the causes of palpitations. And finally, the important thing in SVT, which is the treatment, and immediate and preventive treatment. So what is the difference between immediate and preventive treatment? Immediate treatment means the patient have symptoms, means he has already developed a SVT. Now you are going to treat him. It's kind of an emergency. But preventive treatment, you will prevent it not to occur again. Like in asthmatic patient, we are giving the salbutamol inhaler for the immediate treatment, and we will give the inhaled steroids. We are called preventive therapy. Prevent to not to occur this attack again. So let us start. So this is the normal diagram of the heart with the conduction system of the heart. So what is the conduction system? It is the electrical activity of our heart. Like in electrical activity in our brain, we are monitoring it on the we call it EEG, and in electrical activity of the heart, we monitor it on the paper, we are saying it is an ECG. And now we also see the nerve conduction, we call it nerve conduction system. So these are the electrical activities of our organs. In heart, it is this activity is by SA node and AV node. So this is the SA node, we call it the battery of the conduction system of the heart, which is giving the current towards all the pathway of the conduction system of the heart. So this is the SA node, then AV node, then bundle of His, then left bundle branch, right bundle branch, and Purkinje fibers. So this is the pathway you must know in order, because sometimes in the exam you will face the question. They are asking about the sequence of the conduction system. Maybe they will give 2-3 options which are wrong, like AV node, SA node, then bundle of His, or sometimes they will give you the bundle of His, SA node, AV node. So this pathway you should memorize in the sequence. So why it is important to know? Because when we say supraventricular tachycardia, so these are the ventricles, right ventricle and left ventricle. So supraventricle means this is the ventricle. So tachycardia means racing of the heart. So here current starts from this area. It is not not coming from the SA node. So that's why we are saying supraventricular, means above the ventricle. It's not right atria. There is this battery of SA node. It is on the right atrium, top right atrium. So we are saying supraventricular tachycardia means SVT. It means that there is some problem in the conduction system of the heart. So this is the normal sinus rhythm and supraventricular tachycardia rhythm. Usually in 12 lead ECG, the rhythm strip is the lead 2. So this is the rhythm strip you are seeing on the screen. So normal sinus rhythm means SA node. This is the SA node. Sinus rhythm, normal sinus rhythm means current is passing from the SA node, which is normal sinus rhythm in every human being. But when there is a current is not coming from the AC node, and it is, if you will see here, this is a accessory pathway of the current. It passes from the AV node, then again from the accessory pathway, another abnormal pathway, it goes to the AV node. It is not coming from the AC node. So what changes you will see on the ECG, because sometimes you will see the rhythm strip only. Maybe they will give you the strip and you should know, you should diagnose from the strip. So in ECG we have the P wave, we have the QRS complex, we have the T wave. So P wave is generated when the current is passing from the SA node. If there is no current from the SA node, it means you will not see the P wave on the ECG. Then QRS complex, it means the depolarization of the ventricles. It may current has passed through to the ventricles and ventricles are depolarizing. Then the T wave, which shows the repolarization of the ventricles. Whenever you see the ECG and you will see the P wave, which is preceding the QRS, means before the QRS complex, it means the conduction system, current is passing from the SA node, and we are saying this is the sinus rhythm. But in this ECG, you will not see the P wave before the QRS complex. This is the QRS complex, then T wave, then QRS complex, then T wave, then QRS complex. There is no P wave. It means there is some problem in the SA node, because we don't see the P wave here. We can't say this is the sinus rhythm. This is the tachycardia, because heart rate we can monitor by RR interval divided by the 300. So it is tachycardia, and we are saying supraventricular because ventricular rhythms are there, QRS complex and T. So we are saying it is a supraventricular tachycardia, and this is the accessory pathway by which current is passing. So what is the difference between in the accessory pathway? You will see the supraventricular tachycardia, which has the accessory pathway in the two-way. You will see this white arrows, this is the accessory pathway, and here if you will see this round, this is also accessory pathway. In SVT, usually we are saying atrioventricular nodal, means nodal pathway, which is from the AV node, it goes down and comes again to the AV node, and AV node goes down, comes again to the AV node. This is the AV nodal supraventricular tachycardia. And in this side you will see the pathway, it is goes from the bundle of Hayes and another abnormal pathway from left atrium and again comes to the AV nodal bundle of Hayes. So this pathway is in the condition of WPW. This is the very important and examiner's favorite point in pediatric age group. WPW syndrome you should diagnose in the ECG, because there are some changes on the ECG when there is WPW. So what is the difference between both? How can I say this is the SVT and this is the WPW syndrome? The thing, this accessory pathway in SVT, which is the AV nodal pathway, accessory pathway is there, and in the supraventricular tachycardia, the difference in the ECG, you will see this pathway usually is quiet, means baby will develop the ventricular tachycardia, supraventricular tachycardia But after his attack, he is free from SVT. This pathway is silent. There is the accessory pathway, but usually it is silent. Sometimes in lifetime, baby has no SVT, but sometimes they have the recurrent SVT. But this pathway, you will feel, you will see the ECG changes. But in this, if SVT has released, you will not see any ECG changes other than the when baby has developed again SVT. But in SVT secondary to WPW, Wolff-Parkinson's Wolff syndrome, Wolff-Parkinson-White syndrome, you will see the changes on the ECG even though baby is not going on, currently he is going on with the SVT. So this is the difference, because this pathway is continuously is there, and you will see the changes on the ECG in the patient who is having supraventricular tachycardia secondary to Wolff-Parkinson-White syndrome. So how to diagnose from the sign and symptoms, recognition and assessment? The early diagnosis and effective management of SVT are vital, as there is a small risk of death. So how would you diagnose? It's according to the age of the presentation. What is the age of presentation? Either it is infants, toddlers, or older children, because infants will not, they are not verbal, they will not tell you I have a palpitation or racing of my heart. So infants have sometimes the same symptoms like the heart failure. They have the gradual onset of increasing tachypnea, and they might having a poor feeding and pallor. And in toddlers, they are usually having recurrent episodes of breathlessness and cold sweats and pallor. These are the presentation, they presented by this way. And in older children, they have the recurrent palpitation and episodes of dizziness and pallor, because these are the verbals. They can tell you about the dizziness and the palpitation. So these are the things you should know about the presentation. If you have received any child who have any baby who is having these symptoms, you should check the heart rate, because this is the only way you can recognize that you are doing to do an ECG. Otherwise, you can miss the diagnosis. So investigations, what are the investigations? Investigations are to confirm the diagnosis by the 12-lead ECG. Continuous monitoring of ECG is also essential, because if there is continuous ongoing ECG, you are treating the patient, you should know that now rhythm is going to be back to the normal. So you can monitor your management as well. So continuing ECG monitoring is also essential, and we should think about the other things, which is the cardiac failure. But the diagnosis by the 12-lead ECG. So this is the ECG of WPW, Wolff-Parkinson-White syndrome. What you will see in WPW syndrome? You have received a baby who is developed SVT, you managed very well, but after that you find there are some changes in the ECG, and sometimes you will face the question in the exam. They will give you the ECG and you should diagnose from the ECG. Then what is this? Sometimes they will give you the history and you have to diagnose. The history means ECG changes by history. So they might tell you that is a short PR interval, Szilard upstroke, or broad QRS. So these are the things you should know about the WPW, Wolff-Parkinson's-White syndrome. Here you are seeing the red arrow was showing the PR interval. This is the P, and this is the PR interval. It is very short. Usually this PR interval is not shouldn't be this short. Usually it is, you will see the P and R interval. Here it is very short, and there is an upstroke when R wave is going, QRS complex, and the R wave going up. There you will feel small Szilard. So this SILAR, they are saying delta wave, short PR interval, and SILAR upstroke, and this is the delta wave. And here you are seeing the QRS complex, which is little wide from the base. You see sharp interval and upstroke of the R wave, you will see that, and this is the delta wave, and little bit QRS complex is wide. So these are the things you are seeing on the ECG of WPW. Otherwise, the SVT we have already discussed how we can recognize in the rhythm stream of SVT. So these findings, it's not necessary you will see in the all leads. Here in this one you see lead 1, VL, V2, V3, V5, V6 and V4. So but it's not necessary you are seeing in all leads these changes. So you should see the specific leads and focus on your diagnosis. What are the differential diagnoses? So these are the differential diagnoses of palpitations, as you know, exercise, excitement, and fever. These are the causes of differential. These are the causes of palpitation. Maybe you will older child, you will receive who comes with the palpitation. So you should know about the stress, anxiety disorders, panic attacks, arrhythmias, congenital heart disease, post-surgical cardiomyopathies, cardiac tumors, anemia, thyrotoxicosis, hypoglycemia. So how can you say this tachycardia is not because of SVT? How can you say? Because you will see the heart rate only, simply it's only in the OPD you can check the heart rate. If heart rate is in between 220 and 300, it is normally in exercise, excitement, fever, anxiety, heart rate will not go that much higher. So if heart rate is above 200 and between 300, usually in infants it is above 200, and in older child it's reached even more than 280, sometimes 300. So you will do the ECG. So you are saying this heart rate is not because of fever or excitement or some other problem. We should look, it could be a SVT. So this is the important things you should know. So this is management. How will you manage the case of SVT? Initially, sometimes in the exam we are seeing in the MRCPCH membership exam, they can't ask about the ABC, but it's wrong. They can ask. So they want us to know how. Sometimes this question is from the emergency. So they want us. We should know about the basic life support and these things. So they are saying, they will tell you about the SVT. This is the SVT and ongoing SVT. So what would be your first appropriate management? So they will give you ABC, vagal maneuvers, and adenosine. So the first thing we are doing the ABC. We will not go for the adenosine and these things. First we have to stabilize the patient. But sometimes they will give you, the patient has been stabilized already and IV access is there. What you will do? The next options, you will not choose the ABC because already patient has stabilized. So they are manipulating the words. Actually, you should recognize from the words in the history. And if it is the first presentation, you should refer to the consultant. And the second line management is vagal maneuvers, diving reflex, one-sided carotid massage. Why one-sided? If you will do the two-sided, the blood will not go to the brain. Valsalva maneuver and ECG recording during procedure. As I told you that during procedure ECG recording should be continued, because if there is sinus rhythm we should stop and we can say this has been resumed. So this is the acute management of SVT. So this is the chart of supraventricular tachycardia, and everyone should memorize step by step, because if there is the shock, either a patient is in the shock or there is no shock. If there is no shock, we'll go on the left side and we'll do the vagal maneuvers, we'll give the adenosine and dose. Sometimes in emergency medicine they are asking the dose only, like adrenaline and adenosine. These are the very life-saving drugs, like prostaglandin. Sometimes they are asking the doses, but otherwise usually in theory exam they don't ask the dose and other things, but the life-saving drugs they are asking. So these are two theory. If you will memorize it, it is valid. Even though it's very rare, sometimes if examiner is not happy, and so they can ask about the dose. So first you have given an adenosine. So it's according to the age. The dose is according to the age, and the maximum is 3 mg. So you gave 3 mg, and then a repeat adenosine. If still ECG is ongoing and SVT is ongoing, then again you will repeat the adenosine, and every 1 to 2 minutes. Okay, so if it is more than 12 years, 6 mg, then 12 mg. This is the standard dose, more than 12 years of the age. But if it is less than 12 years, it is mentioned here 50 to 100 micro per kg. The maximum dose of SVT is maximum 12 mg, and you can continue every 1 to 2 minutes until tachycardia terminated. Why every 1 to 2 minutes? Because this is adenosine, the drug 1 to 2 minutes. Because the short, it has very short half-life. Even sometimes drug reach to the heart, and it will be ineffective. That's why they are saying this drug you should give in the arm, and you should push and raise the arm, so that it should reach to the heart. Not it will be ineffective, and till it is reaching to the heart. A very short half-life. That's why you should give every 1 to 2 minutes. Okay, so discuss with cardiologist, consider DC shock and other arrhythmics drugs as well if it has not responded. So okay, it is if patient is not shock. If patient is in shock, if not delay, you should do the vagal maneuver and establish vascular access as soon as possible. But if you have not established, so you will go for the synchronized DC shock 1 joule per kg. But they are saying they are preferring the adenosine on the DC shock, even though the baby is in the shock, and you have established the IV line, you should give the adenosine. But if you are not that much quicker, so that you have the DFib and everything, go for the synchronous DC shock 1 joule per kg. Memorize the synchronous, not the asynchronous. Sometimes they are giving the answer asynchronous DC shock, and the dose is 1 joule per kg. If it is still in the same condition, SVT is going on, then we will give again same synchronous DC shock 2 joule per kg. First dose is 1 and second is 2 joule per kg. If still ongoing, then we will give the amiodarone. In the exam, maybe they give you the scenario that the baby has given the synchronous DC shock 1 joule per kg, not reverted, and then again they give the 2 joule per kg, still not reverted. What would be your next action? Then you will choose the amiodarone. And sometimes they say we have given the amiodarone, what would be your next action? The next you will give the synchronous DC shock. So by this way they are giving the questions in the exam. So adenosine may be used in preference of electrical shock. If patient taking dipyridamole or has had a heart transplant, give 1/4 of adenosine dose. And an anesthetist must be given for the DC shock if patient is responsive to the pain. If patient is responsive to the pain with DC shock, who will give the DC shock? By the anesthetist. So this is about thank you very much for the listening. If you have any query or any comments, so you can comment, and I will reply if I will see your comment. And I will also post on other topics which are commonly asked in the exam, and we do the small mistakes. If we understand well, we can choose the correct answer. Thank you very much. Assalamu alaikum.